Hey everyone, and welcome back to Breathe Easy, the show where we take respiratory care's messiest, high pressure moments and talk them through one decision at a time. I'm your host, and I'm really glad you're here because today's episode is a big one. Part 6 of our iTXA series, Case Based Clinical Decision Making in High Stakes Airway Bleeding. You know, those calls that get your heart pounding when the airway is bleeding, it's turning life threatening, and every second counts. That's exactly what we're living today. We'll stay case-based and practical, where iTXA actually earns its place, when airway control has to take the wheel, and how you keep a cool head and lead the room when the stakes couldn't be higher. So grab a coffee, get comfortable, and let's walk through managing high-stakes airway bleeding together, one real-world call at a time. Now, in part 6 of our iTXA series, this is what to do when it gets real. In part 5, we talked about controlled, stable cases. This one is about the moments that get your heart racing. Here's our roadmap. We'll define massive hemoptysis and why it's a different animal, and then we'll talk about the priority shift, when the whole game changes from the medication to the airway. I'll give you a key point to anchor on, that this is an airway problem. Then we'll work through a ventilated patient case and where iTXA fits in the ICU. And we'll close the whole series with the final takeaways and a closing message I really want you to carry with you. This is the high acuity stuff. Let's go. So what do you do when it gets real? When airway bleeding turns life-threatening, everything speeds up, and your decisions have to be fast, coordinated, and laser-focused on one thing: protecting the airway. And in that moment, the respiratory therapist is right at the center. You're often the first to recognize that this patient is deteriorating and the one initiating the response. This is a different mode than the stable cases. You're moving away from pharmacology and toward airway control and team-based escalation. The room gets louder, the energy gets chaotic, and your job is to stay calm and prioritize the tasks that matter. Preparation, situational awareness, and a little leadership in these moments can genuinely change whether this patient survives. Let's break down how to do that. Let's define our terms because that matters. Massive hemoptysis is a true emergency. Large volume bleeding that is actually compromising ventilation and oxygenation. Your patient may be terrified, coughing nonstop, and desaturating fast. And here's the key point: that is not the moment iTXA is your first move. First line is airway protection and stabilization. You're rapidly sizing up how bad the bleeding is, deciding whether this patient needs to be intubated, and get ready for advanced interventions. The whole reason we separate moderate from massive hemoptysis is what the treatment pathways are completely different, and mixing them up costs you time that you don't have. So recognize it early, act decisively, because in these cases, delay turns into deterioration fast. This is the priority shift, and it's the heart of part 6 of our series. In severe airway bleeding, your priorities flip immediately from giving medication to managing the airway. So what does that look like in practice? You're prepping for intubation. You've got suction ready to go, and you're positioning the patient to cut down aspiration risk. And here's a practical pearl. If you know which lung is bleeding, positioning that bleeding lung downward can help protect the good lung. None of this happens solo. It takes a coordinated team, and the respiratory therapist is right in the thick of the execution. The skill here is recognizing the moment the situation demands a fundamentally different approach. Stop trying to control the bleeding with drugs and start protecting that airway and securing ventilation. Making that switch in time, and you head off a rapid decline. And here's a key point I want burned in your brain. Severe hemoptysis is an airway problem, not a bleeding problem. Yes, medications like iTXA can play a supporting role in the right scenario, but they cannot replace airway control in a critically ill patient. What actually kills these patients is airway compromise, not the volume of blood itself. Once that clicks, your whole focus changes. You're chasing airway patency and adequate gas exchange because that's what saves lives. So when you're in it, prioritize the interventions that directly affect survival, and don't get anchored on a therapy that offers limited benefit in a high acuity moment. Airway first, always. Let's make it concrete with a ventilated patient. Now, you've got a patient on the ventilator who's bleeding into the airway, blood visible in the endotracheal tube. The ventilator alarms are going off, and here's the thing, being intubated doesn't even make you safe. That blood can still wreck gas exchange and threaten airway patency. So you're evaluating ventilator performance, checking whether your suction is actually keeping up, and watching overall stability, all while weighing adjunct therapies. This is genuinely complex. You're juggling ventilation, clearing secretions, and coordinating with the team for the next intervention all at once. The respiratory therapist is balancing all of those priorities in real time. The takeaway is stay vigilant, stay adaptable, because these situations evolve minute to minute, and you have to evolve with them. So where does inhaled TXA actually fit once you're in the ICU? Think of it as an adjunct, a supporting player, not the star, and definitely not a primary solution for airway bleeding. It can help stabilize localized bleeding, sure, but only as a part of a bigger plan that includes monitoring, airway management, and a clear escalation strategy. And here's the warning I keep coming back to. Never let giving TXA delay the interventions that actually fix the problem, like bronch or interventional radiology. Know its limits, stay proactive, and use it as one tool in the kit. Do that and you optimize outcomes without ever letting it quietly delay the care your patient really needs. Alright, let's bring this whole series home with the final takeaways. Across every level of severity, it all starts with one question: is this patient stable? That assessment is the foundation for every decision that follows. As respiratory therapists, we lead the bedside evaluation, we keep reassessing, and we coordinate with the whole interdisciplinary team. And remember how we frame escalation is proactive move that protects your patient, not a sign that you failed. Build these habits in, and you'll handle both the routine cases and the high acuity ones with the same steady judgment, better outcomes, and real leadership when it counts. That's the skill set we've been building across all these episodes. And the line I want you to walk away with, the heart of this whole series: patients don't die from the bleeding, they die from airway compromise. So above everything else, protect that airway. Inhaled TXA absolutely has its place in the right scenario, but the responsibility always comes back to you to make sure the airway is secure and the patient is ventilating appropriately. So take what we've covered across all these episodes and use it. The next time you're at the bedside and the stakes are high, keep the airway safe and you'll make a real difference where it matters most. Thanks for listening to Breathe Easy. Take a deep breath and I'll catch you on the next one.